Hey everybody, Scott here with a quick programming note. We are coming to you on Tuesday rather than our typical day, which is Thursday. That is because in this episode of RetinUp, we preview the Angiogenesis 2026 meeting, and the registration deadline for that meeting is Thursday, February 5th at 3 p.m. Eastern. We wanted to give all of our listeners enough time to register for the meeting after listening to our conversation about it with Tom Albini. Our next episode will be back on the Thursday cadence. All right, enjoy the show. Welcome to RetinUp. I'm Scott Krzywonos.
And I'm John Kitchens.
And today we are joined by Dr. Thomas Albini. He's a professor of clinical ophthalmology at the Bascom Palmer Eye Institute in Miami, and he is a course co-organizer at the Angiogenesis, Exudation, and Degeneration meeting that Bascom puts on each year. Dr. Albini, welcome to the show.
Yeah, thanks for having me. Nice seeing old friends, and happy to discuss angiogenesis. Very excited about this upcoming meeting. That's in 2 weeks, so it's going to be a great one.
And Tom, let's get this out of the way first. Angiogenesis was your brainchild, right? This is your baby?
Yeah, only second to BBS, which I also created single-handedly. No, it's everybody knows this meeting started back in the days of Macogen, 2004. Phil Rosenfeld put it together. And it's been, his meeting in and out. Dr. Flynn and I help in some of the logistics and some of the meetings, but 99 and that's not an overstatement at all. % of the work for this meeting is due to Phil Rosenfeld. So I'm honored to speak here, but I'm glad you brought that up at the beginning. I did get Phil's permission to have this discussion this morning. So I said, "Are you sure you don't want to do it?" He was like, no, you do it. So I'm happy to represent him, but I'm here trying my best to channel my inner Phil.
Well, that's fantastic. And we're doing something new here on RetinUp, which is we're going to do some pre-meeting coverage. Scott, do you want to talk a little bit about what that is intended to do?
Yeah, we are hoping to illustrate to our listeners what they should expect from a meeting that's forthcoming, right? It's easy to look at meeting wrap-ups, but there aren't a lot of spaces where we talk about what to expect at the meeting. These agendas can be dense. There can be a lot of stuff in there. They're not easy to comb through. So we're hoping to go through and pick out a couple topics so that when you do attend the meeting, you have something to focus on.
Just a couple things that I think are important to get out there, and that is every year we have an issue with people trying to register for the meeting the day of the meeting or the day prior to the meeting. So unfortunately, the way this system is set up, we really need people to register by Thursday, February 5th at 3 p.m. Eastern Standard Time. So that the meeting is closed, almost impossible to get into after that time point. And just so people know, in years past, and I'm almost 100% certain this year also, we'll have the ability to stream the meeting afterwards, but it's not edited for streaming until about a week after the meeting. And then after that, if you've registered, you've got about 3 months to access, and you can access it repeatedly and watch it at your leisure over and over again if you want any of the talks that are on there. So just wanted to get that out there because this always comes up with people texting me. I think John may have texted me at some point. Very hard to get in last minute. And as much as we love to be friendly, the system really does not allow for people to register after 3 p.m. on Thursday.
Can you register after the fact so that you can look at the archive?
I don't think so.
Okay, so
we still want people predominantly to be driven to the live version of the meeting. The concept is that we do have panels, we do have live discussions. We want people to participate in the meeting at the time. And the streaming is only available to those who register ahead of time.
And Tom, I got to say, it is probably the best single day online meeting that you can attend this year. I mean, it really has so many relevant talks that if you do this, you are covered at least through ASRS and Academy, unless there's some huge announcement as far as staying up to date with the latest advancements in what we do, in the research in what we do.
Yes. It's a marathon. We have 84 talks this year, 9 sessions, 0 breaks. So, and it's starting at 7 in the morning and going past 8 p.m. at night. Most of the talks are 8 minutes. There's some 5-minute talks, but it does cover a full variety of who's who in retina from around the world, and what's important in retina and clinical trials development and basic science of macular disease. It's really an amazing group of talks.
And Tom, before we dive in here and start talking about some of the individual sections and talks, how do you all select the talks for angiogenesis?
Again, Phil does most of the heavy work here. Uh, Typically, people either will email with ideas for talks that they have. There's a number of speakers that are repeat speakers over and over again, some of whom have been coming for the full 20 years that the meeting's been on. So it goes a lot by, invitation in terms of people that have been repeat speakers, and Phil loves to have the same group of friendly faces there every year. Um, but also new things that are coming in, and people either Phil reaches out to people or people reach out to Phil with ideas. And the concept in terms of clinical trials is to really have complete clinical trials, either phase 1, phase 2, or phase 3 trials, um, that are ready to present, where the data's been looked at. So those are the criteria that we have.
All right, with that said, let's get into a discussion and a dissection of the agenda. The first thing that we noticed on the agenda is that there are AI talks scattered all throughout the day, starting as early as 7:20 and going well into the evening. They're covering a handful of disease states, and we're looking at AI and machine learning in various capacities. Tom, is this the most AI talks angiogenesis has had? I have to think it is.
I think that's right. I mean, I'd have to go through the agenda last year. I know we had at least one or two last year. My suspicion is that this area of research is going to keep growing. The power of AI and the power of AI and imaging is obvious. I think to most of us that we're going to be using AI in our clinics. We're going to be using AI in research. I'm really looking forward to Aaron Lee from WashU, who's going to be doing an overview of AI and deep learning for AMD, and then a number of other talks there. I'm not going to go through all of them, but I think more and more we're going to have these algorithms helping us do our jobs and interpreting imaging for us in lightning speed. So I I think, yeah, we've grown. I think on the other hand, you could say this is a lot of talks, but I think it's the tip of the iceberg. I would imagine it's going to be grow exponentially over the years.
Yeah, you got to be up pretty early in the morning to catch Aaron's talk. It's a 7:20 talk, so I think it's the third talk. Just following Emily Chu's analysis of OCT classification of AMD. But Tom, AI, when you go to these meetings and see AI in the context of research, certainly does look exciting, but it feels like it's a million miles away from being clinically relevant. I mean, we have to get FDA approvals and things like that. When do you think we'll actually start seeing stuff in the clinic that's a true difference maker as far as AI is concerned?
I think soon, but within the next couple of years, I would imagine we'll have it. We have FDA approved screening for diabetic retinopathy already available. So ophthalmology has kind of, I think, really been the pioneer in that field, and I think we're going to continue to be. And it just makes most sense to have AI assist with interpreting imaging. Um, I'm not aware of what all the regulatory hurdles may be, and of course the regulatory world is always changing with the political changes and whatnot. But I would think it would be soon. I want it to be soon. I think we might see it first in some clinical trial and in clinical trials and evaluation of imaging for patients that enroll in clinical trials. Um, but I hope to have it in clinic, within the next couple of years. I don't think it's going to be decades before we see it. I think it's going to be a couple of years.
And are you guys at Bascom doing anything with AI?
Not for routine clinical practice yet. Um, I just on our own, a number of the clinicians, and I think you've done this as well. In fact, I think I may have gotten the idea from you, John. I have taken OCTs and just put them into the various AI uh, uh, um, platforms that are out there. And it's amazing how well even that does. I mean, it just looks through the literature and picks up and tells you what's out there. So, in that informal setting, we've started some trials in using it for uveitis cases, for example. But we don't have an official AI research protocol that I'm aware of.
All right, moving on. There's a handful of early phase GA data drops that are happening at the meeting. These start right at noon with a talk by David Zaks, and then they go on for another half hour or so. Dr. Albini, what are you most looking forward to with this?
I just want to see if we have increased efficacy and safety in treatment for GA. And I think the safety piece, I'm very much looking forward to talks on oral agents that are being used. And um, the Roger Goldberg is presenting on oral zervamecine, if I'm pronouncing that right, which to me, from well, from what I've seen, the efficacy side seems to be similar to the efficacy that we've seen with the intravitreal agents. Now, I'm looking forward to learning more about the data. I don't know definitively that that's true, but it looks like it has the potential anyway of having similar efficacy and a hopefully lower rate of complications. So, um, I think having more agents at our disposal hopefully will lead to some combination therapy, which will increase efficacy and keep the safety signals down to a minimum. So very exciting time. I think we're seeing the beginning of treatment for GA kind of roll out, and who knows where we'll be in a couple of years. But I think we're probably going to have some form of combination therapy with systemic treatment and with intravitreal treatment.
And Tom, the talk you're referring to is the phase 2 magnified trial that Roger's going to be talking about, and that's at 12:20. So definitely one you want to catch. How much can we garner from a phase 2 trial as far as efficacy is concerned?
Well, I think you always have to take phase twos with a grain of salt, but one thing you can see is whether it's likely that they're going to move on to phase three, right? So if there's a good signal there, then we can be excited that we'll get more data to look at it more definitively in a phase three trial. A lot of phase twos that don't work in phase threes. There's a lot to be said about trial design and how much of the trial design you want to repeat, or whether it's smart to tweak things to hedge your bets and increase your chances of succeeding with the phase three. Lots of different theories about that people have. But yeah, clearly, if a lot of things have made it in phase two that don't make it in phase three. So good point taken. But it does tell you whether we're going to see a phase three.
I also noticed that in the later half of the 11 o'clock hour, 4 talks on perfusion and AMD.
Yeah.
Is this something we should be thinking about, or is this just kind of crazy talk?
I think Phil thinks we should be thinking about it.
Hey, if Phil thinks it, then it's not crazy talk. If Phil thinks it, it's probably legit.
There's something there. The safety side is a big issue. Um, but I think it's interesting pathophysiologically, of course, how much of AMD is related to circulatory compromise, and I think these studies are telling us important things about that. Um, but I would be surprised if this was rolled out in the United States as a treatment for AMD before AI is. I think AI is going to be years and years earlier, but I think it's something worth watching. And I'll be honest, I don't know exactly what's going to be covered in these 4 talks, but I'm certainly looking forward to it, and it's an out of the box way of thinking, and maybe it's becoming less out of the box. I think we've had talks on this. Well, I know it. I think the last 2 years at Angiogenesis. So it'll be interesting to hear how things are developing with this research.
Oh, Tom, when you talk about a combination therapy, something both intravitreal and systemic, is that all complement based, or is that going to be complement based from the intravitreal side and then some other approach systemically?
Well, Scott, I'm glad you asked that question because the molecule that Roger's going to be talking about is not a complement inhibitor. And I can't do justice to tell you what the target is of that molecule. You'll have to listen to his talk, but I think that the we'll probably have hopefully more targets intravitreally too in the future if that's what's needed. Um, but uh, but at least some of these targets are going to be non-complement targets.
Yeah, Tom, do you think in 5 years from now we're still going to be using complement targeted therapy, or do you think it'll be something else?
Um, I don't know the answer to that question. I'd be a much richer man if I could answer those types of questions. But I think my suspicion is that it's going to be combination therapy. I still think the signal for anti-complement is strong. It's maybe not as strong as many of us would like it, and there might be issues that we have with balancing it with safety. But I think that we're going to find new molecules, new targets, and new modes of delivery that are going to change the field a lot, I think, over the next decade.
And is inhibition of systemic complement really that important? Or can you get it done from an ocular standpoint? I'm asking you questions that we obviously don't have the answer
Yeah,
to
I
yet,
I
but
I can tell you this, there are lots of people who have spent their careers working in this field who think that it is. So I think that we're going to see also systemic anti-complement. Um, it's going to allow for a much more robust complement inhibition than what intravitreal treatment allows for. And the safety side of it may be reasonable. I think the trials will have to bear that out. Um, but um, but I think very smart people think that there is a benefit to more robust complement inhibition by using systemic agents.
and I love it, Scott. Here we are now. We're at 2 o'clock on the agenda for the angiogenesis meeting, and we haven't even touched angiogenesis.
Well, it's not angiogenesis if you skip wet AMD. And yeah, by the time we get to 2 o'clock Eastern, which means everyone's having lunch in California, we start talking about some of the big AMD studies that are being shared this year. I'm curious not only which studies you're most looking forward to, but I really want to know how much space there is to improve in wet AMD. Both John and Tom, any thoughts on this?
Well, durability is, the obvious piece that we're still moving on um, uh, with the sustained release implant from Genentech. I think we have new data coming out. We have real world data for a lot of these agents, how they're being used. We have the TKI inhibitors that are coming out with sustained release platforms. So I think all of this trying to um, improve efficacy, reduce the chances of patients missing injections for various reasons, hospitalizations or whatever insurance changes and different things that we all see in the real world that would be very nice to avoid by having more durable treatment options. Um, and trying to eliminate as much as possible the continued monthly injection patients, which we still all have. So um, I think it's exciting. I don't think that the improvements in wet AMD are over. We still have room to improve, and I think we're going to continue to see new agents in this area.
What I love, Scott, is if you look, if there's any hour to not miss in this meeting, it's bookmark that 2:45 to 3:45 hour because you literally get every single gene therapy kind of covered in that single hour there. And I just want to point out the 2:55 talk by Charlie Wyckoff. Charlie's one of the smartest guys in retina, and he's going to be talking about Ixavec phase 2 Luna study. Really interested in this. This is the one that Lilly, I think, acquired, the gene therapy. We hear a lot about 4D. We hear a lot about RegenXBio, but I think that we're going to learn a lot more about Ixavec during this meeting. What do you think, Tom?
Yeah, I mean, I think we have good representation from the protocols, different modes of delivery to suprachoroidal. I'm excited to hear about that. I've always been hoping that pans out. And gene therapy, very exciting. A lot of movement there, a lot of different protocols that are out there, and I think this is a great way to review all of them in one place at one time.
And we got to talk starting right off of that at 3:45 with home OCT validation and real world management with one of my favorite people, Nat Lowenstein, and that's just a really fun, sweet person. Tom, home OCT, are we ever going to see it in the States?
Yeah, when is this getting here?
We've been talking about it for a long time. So the biggest skepticism that I have about it is the fact that it's been available, and then there were issues with reimbursement and various things that kind of took it off, and now we have a well, I mean, we've had home monitoring for a while, sorry, but the better to say. Now the home OCT, I think will be there. I look forward to hearing what the latest is on, the paths forward for getting this approved by regulatory agencies and getting it into our hands, and getting reimbursement done with it. But I think it's a no-brainer that patients want it. Whether it's affordable and something that everybody can get, I think needs to be seen.
Dr. Albini, what about gene therapy just as a approach in general? Because I would think that there's something inherently inflammatory about injecting gene therapy that might counteract any initial effects of gene therapy and therefore just render the whole treatment moot as an entire class. Am I overthinking this, or is that a real risk?
Well, it's a very good thought, and I don't think you're overthinking it at all. I think that's a big part of the puzzle, and I think every one of the companies that are developing agents in this class will tell you that that's a primary concern of theirs. Um, Inflammatory side effects, we're also seeing sometimes that we're seeing some changes in the retinal pigment epithelium in patients after they've been exposed to the gene therapy and it's not clear what the clinical significance of that is, I think, to most people yet. So it's exciting. There's a lot of stuff out there. It's not clear what the risk benefit ratio is going to be for patients, and the specific vectors, the delivery mechanism, all of that needs to be worked out. It is not straightforward, and it's exciting to see how this trial data comes out.
Let's move quickly onto imaging before we take a break. Doctors Albini and Kitchens, anything in here that is particularly attractive to you? I know we talked about imaging vis-a-vis AI, but I'm curious about imaging for imaging's sake.
Well, Tom, I'll tell you, in my mind, it's really when are we actually going to see some imaging that we can use clinically to help us in managing the GA patients, not just in diagnosing them with GA and not just seeing gross progression, but actually being able to tell a meaningful difference or demonstrate a difference for our patients.
Yeah, I think that, that gets us back to AI. I think there's a lot of hope that imaging plus AI will be able to pull out who the winners are and who the patients are that are most likely to benefit, or to even just be able to demonstrate to a patient or try to predict with some degree of certainty what their future is with and without treatment. I think all of those things are coming our way. But I think also um, the two things that I'm excited to learn about from this angiogenesis are talks about OCT simulated fluorescein angiograms. So there's a talk that's being given about um, uh, uh, trying to create pictures of vascular leakage and fluorescein angiograms from OCT data. and also increased visualization of the choroid. I'm always interested in choriocapillaris flow and so forth. A lot of, white dot syndromes and uveitic conditions, but also in AMD. So I think there's a lot of new exciting things that are there. Um, how much they're going to help us manage our geographic atrophy patients, I think it's there, but protocols for measuring um, ellipsoid zone loss areas and following ellipsoid zone loss or retinal pigment epithelial loss over time are coming our way, and we'll be seeing some of that in angiogenesis for sure.
Yeah, so Tom, the two talks you're alluding to, 8 a.m. Ricky Wang on imaging of the choriocapillaris, which will be a great talk. It's one of those kind of reading the tea leaves. And then at about 5:20, we have OCTA leakage microaneurysms via AI inferred FA from Toshinori Murata. Um, and that would be amazing if it could demonstrate, because we see the structural changes with OCTA, but you don't really see the dynamic pathophysiology of what happens in an OCT or in a real true fluorescein angiogram. So if you can actually simulate that in a realistic fashion, we might be one step closer to getting rid of, IVs in clinic for angiography.
I couldn't agree with you more, and I think unfortunately we're not there yet as far as I know, but I'm really looking forward to this talk. Hopefully I'm wrong. Maybe we're there, but I can't wait to see what this is. And this is the strength of angiogenesis. A speaker from a university in China that's given this talk. So it'll be great to see what research they have in China and how close we are to that.
We're going to take a quick break. When we come back, we're going to discuss talks on IRDs, some legacy trials that are coming to an end, and some non-intravitreal injection routes. Stay tuned. Hey there, listeners. If you are subscribed to the show, thank you. If you're not subscribed, do so on your podcast platform. Alternatively, you can sign up for our newsletter where we will let you know when we have a new episode dropping. I promise we will not spam you. We are only telling you when we have a new episode. You can do that by visiting our website, retinup.com, RETINUP.com. Thanks for sticking with us. Let's get back to the angiogenesis agenda. The first thing that we want to talk about in this block is IRD therapies. They're all over this agenda, and I think IRD therapy is cool. Dr. Albini, when you guys were selecting talks for this meeting, or when Phil was selecting talks for this meeting, how did you decide which IRDs to focus on?
I think we're looking for the most interesting trial data that's out there. And I think we got a great collection of talks. And this is a section that's been growing. I mean, I remember not too long ago, probably 7 years ago, we had one talk on IRDs that used to be given by Byron Lamb most years, and now it's a number of talks. So it's also interesting that there are more people in this field than there used to be. So I see some new faces of people who are involved in clinical research and IRDs, and I think that's great. So very exciting, and lots of things that we're looking forward, gene therapy for these conditions, optogenetics. So I think it's going to be a good session.
Tom, can you tell us a little bit about what optogenetics is?
So optogenetics is technology where other cells are given the ability to respond to light stimulus that don't normally respond to light stimulus, and that can be bipolar cells, other neural cells in the network, and then those cells can then act as photoreceptors.
And the beauty of it is, as I understand it, you don't have to be gene specific with this. You can bypass. It's not like you have to find an RPE65 mutation. You can treat these patients and their bipolar cells or whatever the cell is you're targeting to transition to this light receptor can now suddenly be the photoreceptors or act in a photoreceptor-like way. Am I right on that?
Yeah, I mean, that's the hope, right? And there's probably not a week that goes by that a retina specialist doesn't get a question from somebody, "Hey, doc, when are you gonna be able to fix my retina over my whatever, disciform scar, multifocal choroiditis," whatever it is, some degenerative process or a scarring process in the retina, and um, so if there is viable inner retina left, this provides a hope that you might be able to restore visions to all sorts of conditions. So, but anyway, we got starting with inherited retinal disease makes the most sense for sure. We'll see how that develops.
So it's not just gene agnostic, it could be disease agnostic.
That's my understanding.
And what I love about the inherited retinal degenerations session, which is one of the last sessions starting at 7:15, is you all lead off with the wallaby and platypus studies. Bob Bish School is going to be giving these, which are actually traditional, I think, inherited retinal disease study. But I love the naming of this. And then David Boyer, a real legend in our field, is going to be actually talking about an optogenetics study for RP. So those are going to be two really interesting talks to tune into.
Yeah, if you can make it to 7 p.m. That's 12 hours into the meeting.
You gotta
Not
you
for the
gotta
light of
plan your
heart.
nap. Plan your naps during angiogenesis so you can power nap during it. I think the last one I took about 3 or 4 power naps to be able to stay focused to listen to all these great
Yeah,
talks.
I had a discussion with my wife that I'm out the entire day. No dinner plans.
Yeah. That's easy for you because you're a moderator. My wife just sees me walking around carrying the laptop, and she's like, "Can you do something?" And I'm like, "I can't miss these next 4 talks." So it's a little harder when you're at home and actually just tuning in.
Tom, at the top of the show, we talked about some systemic treatments. This was for GA, but there are some non intravitreal injection therapies that could be considered systemic for some other diseases too. So we see eye drops, we see some oral therapies, and some subcutaneous injections. I assume that all of these would be administered at home. What talks in here do you think are worth seeing and sitting in for?
I think it's very hard to predict which ones are worth seeing because sometimes the title seems like something that's not going to bear fruit. Um, and like I remember the photobiomodulation talk that was given years ago, and I was like, this is, whatever. But then when I saw the data, I was like, maybe there's something there. And now that's been with us for a while, and we do have a photobiomodulation update um, coming from Dr. Ladd from Duke at this meeting. So um, I uh, I think it's hard to predict, but I will tell you that there's a buzz about um, oral agents for diabetic uh, macular edema, diabetic retinopathy that I'm looking forward to learning much more about. And I do think that there's some good research and some good data coming forward for a number of oral agents.
Yeah, Tom, I'm surprised there's only one photobiomodulation talk, and it is Elnor's. It's in the last half of the noon hour, and she's giving an extension study, the LightSight 3B extension study, not related to angiogenesis, but are you all using photobiomodulation at Bascom?
No, we've been slow adopters. We have a number of more rapid adopters in the community. I think in general, we've been more skeptical here. We've talked about potentially doing a real world study. I don't know that anybody's really taken the bait to do that, but um, uh, John, I thought you were doing a real world study. Are you?
So we have a unit, and I think, the big issue that we have with our unit is twofold. It's number one, the fact that the physician has to be in the room to actually do the treatment, and that's been a real sticking point for us because we're so busy. And the second thing is the cost. It's out of pocket still for most patients, and it can be pretty expensive for patients in Kentucky. I would imagine a place like Palm Beach
Mhm.
would be an interesting market for something like that, where you have more affluent patients and whatnot. My experience, though, with about 6 patients has been 3 out of the 6 have said that they can tell a difference, with their vision. Of course, highly motivated patients and whatnot, but they've seen enough of a difference that they wanna go through a second round of treatment.
Yeah, I mean, I really think, and I think the majority of the faculty here would think that it belongs in the too good to be true column. But I'm very open and interested in seeing data. So, I'm looking forward to hearing more about it.
Some of these other routes, talking about drops and subcutaneous injections, I'm curious how viable you think those are.
Yeah, I mean, the proof is in the pudding. So I think somebody thinks they're valuable enough to put money up to do a trial. There's probably something there. I want to see the data. These are great presentations to hear the synopsis of what's out there. We'll hear the best case scenarios for all of these different delivery mechanisms. Um, I think that patients don't like intravitreal injections, just to state the obvious. So even though as retina specialists we've come to love this mode of delivery, it probably would not be the way patients would dream up treating anything. Pills are probably the preferred mode of delivery for anything, so long as there are no side effects, which is often the problem with potent systemic medications. So we need to see how that pans out. It's definitely worth seeing. There's lots of benefits to systemic administration if you can avoid systemic side effects.
And Tom, the last time I saw the topical dexamethasone eye drops for diabetic macular edema, actually was surprising at how well it works, side effects aside. And I think Barry Cooperman is going to be giving an update on the Diamond Stage 1, Phase 2, Phase 3 trial at 6:45. So that's definitely another one that's worth kind of tuning into.
Yeah, I mean, I would argue a lot. Most of these are worth tuning into, but I agree. There's just so many of these different treatment strategies and things that are out there. I'm looking forward to hearing all of it.
Thinking further down the line, let's just assume, I don't know, 5 to 10 years from now, there are an oral, a drop, and a subcutaneous injection approved. Does that shift the burden of care from a retina specialist to a PCP? Because they can now start identifying patients with diabetic eye disease, maybe because there's improved screening, maybe even some of those AI tools we talked about? Or will retina specialists still be running point on care for patients with diabetic eye disease?
That's an interesting question. I think in some areas where there aren't enough eye disease providers, that might be a great benefit. That there may be certain areas where imaging can be obtained and imaging can be reviewed either by AI or by a remote physician, and a treatment plan can be drawn up that can be administered by a non-ophthalmologist. But I still think that optimal treatment, again, I, my vision is, and that it's probably going to be some combination of things. So I don't think it's going to be a simple one magic bullet pill that's going to cure all ailments. But I think you're going to need some combination of therapies, and so I think local therapy is still going to play an important part. And I also think that careful evaluation of things is going to be required and going to be best done by a local eye provider. So I think the majority of patients are going to be seeing eye care specialists regardless. Um, but there may be a huge benefit in some areas where there isn't access to retina specialists, that other providers may be able to administer some of these treatments.
Final chapter for our discussion today. There are two landmark studies that are saying goodbye. These are pretty big studies. John, where do you want to start?
Yeah, I mean, one thing that's near and dear to my heart, Tom, is the port delivery system, with Susvimo. And somebody who's been very instrumental in that, Dante Paramici of 425, is going to be talking about the Pagoda end of the study results, port delivery system for the treatment of diabetic macular edema. I think that this has really been our first foray into extended duration therapy and disease suppression, and so it's going to be interesting to hear what Dante has to say about that.
Yeah, I mean, I think these are two high impact studies in terms of changing practice patterns. I think I'm, very ready to adopt um, high dose Eylea for vein occlusion patients. And I'm getting, I haven't done a port delivery device yet myself, but I'm becoming increasingly interested in the strategy for certain patients that have a difficult time coming back and want to decrease number of injections that they're getting. Um, as you know, down here, the Keys are a funny area where there's no retina specialist out there doing injections. So these folks are driving like 3, 4 hours, and the traffic's just getting worse and worse in South Florida to come back for intravitreal injections. So, um, I think that there are certain patient populations that where this would be an ideal thing to offer them. So I'm really looking forward to both of these talks as well.
Yeah, the second study Tom's alluding to is Varun Chaudhry at 4:55 is going to be giving an update on 8 milligram of aflibercept for RVO, the Quasar study. It's going to be the final results. And I was really surprised at how many patients in that study could get out to 3 to 4 months with 8 milligrams. So I agree, Tom. It's a real game changer.
There's an update on Incelto, also the new FDA-approved Mactel gene delivery device. I still think that's really cool technology that's unlike a lot of the other treatment strategies, and whether or not that ultimately pans out um, to be useful for other diseases outside of Mactel, either with CNTF or loaded with a different molecule, I think yet needs to be seen. But if it does gain wider use, I think there's a potential that the Mactel study becomes a classic study.
Tom, let me jump in right there. Let me ask you, have you guys done any Inceltos at Bascom Palmer?
I've done one, and I think that's the only one we've done at Bascom Palmer post FDA launch. We've done, I forget, 30 to 40 in clinical trials prior to that. So we've got experience with them. Um, but I, uh, it's actually been smoother than I thought, but we've been careful because of the insurance verification piece to it, and making sure reimbursement comes through. But uh, I think it's a great technology for MacTel patients, and they're interested in it. Have you guys
And do
done
those
any?
No, we haven't because of the same issues, and I'm so happy to hear that you've done one
Yeah.
because I would think, gosh, if Bascom Palmer hasn't done this,
Right.
who's going to be able to do this? I mean, you have a hospital, you have a university backing, you're the number one eye institute in the world, basically. And if Bascom's not going to be able to do it for whatever reason, insurance primarily, who can do this? So that's actually really encouraging that you've done one. Do the patients actually see any better after they have this done?
No, I mean, as you know, this is to slow down the progression of ellipsoid zone defects. So um, they're not better. The eye's a little swollen. Although within a week or two, the one that I did, the patient came back and he was back to baseline, not any worse. But from the trial patients that we've seen, we definitely see patients who notice that they're doing better in the treated eye than they did in the contralateral eye. So um, they do notice that. But but yeah, it takes a long time, just like the anti-complement treatments, to demonstrate a benefit here. I think that here the visual acuity is dropping, and the patients really, um, notice a more rapid vision loss initially. So I think there's a lot to be gained by these implants, and we do have, again, a talk on the safety side
Mhm.
that's going to be given. Who is it that's giving that talk? Um, and then Martin Friedlander, who gives us our update on MacTel in general. He's been involved in basic science research with MacTel in the clinical trials, is giving his update on MacTel also.
Yeah, actually, the talk on Incelto is Lloyd Clark at 7 or 7:10, actually.
Yeah. So I'm looking forward to all of those, and I hope I can keep myself in front of the computer for 13 hours to make it through all that.
Well, you better. You're a
Yeah,
co-organizer. If you can't, then who can? Dr. Albini, final question. I'm in Philadelphia. It is 14 degrees today. I used to really look forward to going to Miami in January for Angiogenesis. Any chance this thing ever goes back to an in-person meeting, or is this a permanent shift, you think, staying in the virtual space?
well, that's the way you ask that question. It's easy to answer. Of course, there's a chance. Is it likely? I don't think that Phil thinks that we should do it. And again, the benefits really have been the international participation and the increased attendance and registration. So roughly the registration doubled from when we went virtual, and I think that was surprising and unanticipated, and it's nice that so many people can uh, see the meeting and hear all these talks, and so it gives all of our speakers a um, much larger audience. A large portion of the audience is corporate too, so it's obviously aimed at physicians primarily, but there's a large segment of not only pharmaceutical but investors, and I think a lot of people are hearing these talks. So it's a nice thing for the speakers also, although they miss out on the weather. We're trying to get the Atlantic Coast Retina Conference. Um, that is the name of it, right? Atlantic Coast. Yeah, we're trying to get the Atlantic Coast Retina Conference to come down south. So we might have a Miami version of that every so often, every 3 or 4 years, coming in the future to kind of fill that void of a February meeting. And there are other meetings in Miami that are starting out in the spring, and hopefully Vitbuckle comes back here. But I really do think that the being able to have all these talks from so many different people from so many different parts of the world, and to have everybody participate every year is best suited for a virtual platform like this. So I see where Phil is coming from, and I tend to agree with him. It would be hard to put this on, especially in a single day. But it would be hard to put this on, I think, live, whereas it's easier to do with the virtual platform. So I would say to those people that if you want to come down to Miami, you're welcome. There's good internet access down here. So
Yeah, we could just watch it from the lobby of the Mandarin Oriental Hotel.
you can
Yeah.
join me in my office, and I'd love to watch it with you, but I think it wouldn't be the same really to what this meeting has become on a virtual platform. And I think I love, Vitbuckle to me, just to put in a plug for my other favorite meeting, is a great meeting that would absolutely not work as well in a virtual platform. That is an in-person meeting, and there's a lot about networking at that meeting that goes on that you can't possibly duplicate. But I think also in my mind, the flip side to that is that there's a lot that goes on the virtual network online with this meeting that would be impossible to duplicate in person. And even though there's not a year that goes by that I don't get 10 or 20 people telling me that we need to go back to live, and I get it. I don't think it would be the same meeting.
All right, very well. Well, Dr. Tom Albini, thank you for joining us on RetinUp.
Yeah, my pleasure. Thanks so much for this discussion. It was great.
Thanks, Tom.
Yeah.
All right, everyone, subscribe to the RetinUp newsletter. Visit retinup.com or scan the QR code on your screen if you're watching on YouTube. And please interact with RetinUp. If you want to leave a comment on the YouTube channel, we might address it in our next episode. And if you want to hit our mailbag, send a voice recording to info@retinup.com, retinup.com. And you can get the feedback and thoughts on what's happening in retina or in ophthalmology or in your life in general. We promise not to spam you if you sign up for the newsletter. Thanks again for listening.